Well, thank you. It's good to be back. It was about 3 years ago that I spoke with a group up here. I think were we out at the mall? Yeah, we were out at the mall, and it's interesting where we are today, 3 years later, from where we were 3 years ago. There was a lot of speculation 3 years ago where we were, where we're going to be going, what it's going to look like. And I'm sad to tell you where we are today is we're almost in the same spot as far as knowing really where we're going, what's going to happen, what the impact is. Although there's a cloud growing almost like a storm out there. And it's not a political statement because the one thing that I do know is that 3 years ago maybe it was political. It's not political today. This is called real life, and this is called serious, and it's hitting everybody regardless of whether a person's a Republican, a Democrat, an independent, or no party affiliation whatsoever. I'm going to start with a little bit of show and tell since we're in school, if that's all right. And we probably have some, do we have any past school board members here? Or school teachers, school administrators? Perfect. Over on my left, the stack of papers, which would be, I guess, on your left, the short stack, that is the bill. 2,900 pages is what it is now. That I would guess that probably 95 to 96% of the people who voted to encumber this country with this piece of legislation never read. I don't blame them. I mean, they got it about 48 hours before they're supposed to vote, and you're supposed to read that. Now, the second stack of paper that's a little bit higher, that should be 3 times as high, okay, because that's 5,000 pages, the second stack. That is the companion bills that go along with the 2,900 page bill. And if you are going to read the 2,900 page bill, it refers to over 15,000 pages of legislation that is affected by the 2,900 pages. So if you can imagine that stack being 15,000 pages high, now you really know why nobody looked at it and nobody read it. And the individual who probably made the most prophetic statement of all during that whole time was the one who said, we have to pass this in order to find out what's in it. Now you understand why that person said that. Because there's no way that they could possibly do it. So they voted on a bill that none of them had read and none of them had actually participated in reading. So here's my question for the school board. Nice facility you're in here. You've got a brand new high school, which is absolutely beautiful. I imagine there was probably a tax referendum passed for that. And but could you imagine if your local school board said, we're going to increase the tax levy and we're going to put a bill in place of what we're going to do with that, but we can't really tell you what's in it because none of us have read it. But we're going to pass this, and we want all of you in the community to support us and take our word for it. And we're going to put a 1.5% sales tax to pay for what we can't really tell you what we're going to do for you. What would happen at with a local governmental body like that? I think they'd be drummed out so fast it would make their heads spin. And again, this isn't a political issue. But the reality of it is, because it's done at the federal level, so many people have gotten to the point where they just say, what's the use? We can't affect it. We can't do anything. Well, I don't believe that, and I think that the people still can. It's going to take some pretty significant steps to do it. But that's my show and tell for you tonight, and not to depress you, but it does tell you a little bit about what's going on. I've been around the healthcare business for 32 years. I've been on all sides of the healthcare bill. I've worked with a hospital, I've worked with an insurance company, I've worked with physicians, and as Tim would agree, I've been on the right side of the equation for the last 19 years. So, but I have seen all sides of it. The one thing that I can tell you, and Dr. Gibbons will comment on this too, I'm sure, is our healthcare delivery system is not broken. And I take great offense to anybody who says that our healthcare delivery system is broken. What's broken is the regulations of our healthcare system, the financing of our healthcare system, and all of the needless regulations that physicians and healthcare providers have to put up with. That is what is broken. A couple of things, and Aaron's asked me, we were talking about this, he says, well, what would you do to fix it? I said, well, there's basically 4 things that I would do to fix it. So I'm going to start out with a solution, and then we'll talk about a few things that are in the bill. But number one, what needs to be reformed is the regulation. Being in the healthcare business for 32 years, I've seen a lot of regulations get piled on the healthcare providers. Dr. Gibbons will attest to it. Mike will attest to it from the HR side, the human resource side of the companies, the amount of paperwork you have to put up with and that you have to put in place. We feel that from an administrative standpoint in our group in Waterloo, Iowa, is about probably 35 to 40% of our administrative expenses could be eliminated if there would be a meaningful reform of the regulations. Have regulations that actually do something rather than just create excess work. The FDA, the Federal Drug Administration, has bottlenecks on devices and drugs. If they would take the bottleneck off that and get those therapies and those devices and those things to market quicker, you could have much more efficient delivery of healthcare. You've heard this over and over and over again, and you're going to continue to hear it until they do something. But tort reform, and if you're an attorney in here, I apologize. If you're a plaintiff's attorney in here, that is part of the major problem, is that there is absolutely no check and balance on the tort reform across this country, and that cost up anywhere from 15 to 18% of the healthcare bill is because of tort reform. And then the last piece is that if we would put real meaningful thought behind it and have a true electronic record that could go across the country, we could go a long ways towards probably eliminating 30 to 40% of the healthcare costs in this country. A lot of the other things that you're going to hear, they could be, you know, and you'll hear them, I call them red herrings, but the pre-existing conditions. You can fix that very easily. Just on January 1 of a given year, no more pre-existing conditions. Portability of insurance. You don't need that kind of legislation to put meaningful reform in place, because the healthcare delivery system itself, Dr. Gibbons and the professionals who take care of us, that is not what's broken. It's the administrative aspect of it. Now, not all is totally bad with this legislation. There are some things that they get at. They do get at the pre-existing condition issue. That's good. That needs to stay. The portability, being able to go state to state, that's good as well. Low-cost delivery development is being created because physicians and different folks in the healthcare industry are looking for better and less expensive ways to take care of people. That is a good thing that is going. Probably the best thing that's happened out of this whole thing is public discussion. People are sitting there truly now talking about what can we do and what direction can we go with it. So there are a few things that are coming out. Real quick, and I'm not going to go into a lot of this, but how did we get here? I think soaring costs, unchecked regulations, I talked about that. Cost-based reimbursement, when you had so much of the healthcare delivery system was based upon what cost you generated, you got paid. Nobody can disagree that the single-payer advocates seeking control really have seized on this to be able to go to a Canadian or a British-style system. That's just a given. That is, nobody would even debate that. Even a lot of the people who are pushing for a single-payer system, they would not disagree with that. The one thing that was left out of this before the government swept in and took control of this whole system is the most important aspect of medicine that has never changed and it will never change, and that's the patient-physician relationship. When you are with your physician, that's where the key of the whole system has to be reformed at, and that it has to be built around. This system is built around attorneys, it's built around lawmakers, it's built around bureaucrats. And that's, again, that's a fact. That's not a political issue. How did we get here so quickly? You have to look at this, and again, I'm not going to say who was in power, but what it was is in 2009, the party that was in power had enough votes in the House to get it through, and they had enough votes in the Senate not to get it through, but they used something called budget reconciliation to slide it through. Now, what that ruling party will say is budget reconciliation has been used before in the past. The answer to that is yes, it has, but never for anything so draconian or so important that hit us. So the reason why the mass of the population is starting to swing the other way on this, and even some of the people who supported it, Senator Max Baucus, Warren Buffett, Cleveland Clinic, The reason it's starting to go the other direction is because exactly what Speaker Pelosi said, they found out what's in it. And it is not what they wanted. I do have to give a plug for Iowa. The Honorable Senator Chuck Grassley, although he's not the greatest supporter of physicians and some of the healthcare stuff, Tim and I would agree on that. But Chuck Grassley put through a legislation that would block the Congress, the Senate and the congressmen and their staff from getting an exemption from Obamacare. Grassley did that. And what it was is that until the Obamacare passed, congressmen, along with all other federal employees, participated in the Federal Employees Health Benefits Program, and they received subsidies of $5,000 for single and $15,000 for family. They got extra pay for that. But when Obamacare was drafted, Senator Chuck Grassley of Iowa inserted a provision that all members of Congress and their staffs must buy insurance through the Obamacare exchanges. The more that Congress experiences the laws it passes, the better, Grassley said at the time. Since it's difficult for Congress to argue that they be exempt from their own laws, they caved into Grassley's demands. Well, it wasn't that long ago that Senator David Vitter of Louisiana put through a bill, and that got passed, which allowed the $5,000 and the $15,000, which Grassley bills eliminated. That bill brought it back in. So when you've heard that on whatever news outlet you listen to, that's how it happened. That's the, and so it is a fact. So what happened in short is Congress is exempt from this piece of legislation that they had passed. A couple of other quick things. The reason why this is going to be an absolute disaster is what Obamacare requires to work is the state exchanges and the state expansion of Medicaid. 26 states have said we're not going to expand Medicaid and we're not going to put an exchange in place. The Supreme Court has backed them up and said you don't have to do that. So that's a key component to that whole bill that is not going to go into place with the states opting out of Medicaid and the exchanges. The other piece, which is a glaring issue with a major problem with it, is the navigators. The people that are being hired to educate all of us about how to get into the exchange and how to work. That is a glaring problem that they're going to have with the bill, because as Mike can tell you, as a benefits expert who's been in the industry a long time, when you're hiring people off the street and giving them a 20-hour crash course on this law, you've got a major, major problem. In fact, in Waterloo, Iowa, this is just in the Waterloo Courier, local hospitals ready to educate community about Affordable Care Act. And it talks about one of the hospitals down there has hired 3 local leaders to teach the community about the Affordable Care Act. Former Mayor of Waterloo, Tim Hurley, former UNI women's basketball coach, Tony DeCecco, and I have to be careful because my wife said former women's college basketball coach, so I'm not saying anything bad about that. And State Representative Deborah Berry agreed that they are no experts, but they are willing to help understand, or they are willing to help the uninsured and the underinsured get a head start on understanding the bill. And this is right in the paper. They said, we don't understand it, but they are being paid by a hospital to teach the rest of the community. And this is from Coach DeCecco. If you're unfamiliar about where to go and how to go about it, that's where we come in on the ground floor with you. You are not alone. So you've got, I don't know if that's the blind leading the blind or what that is, but I could go on and on about these are real, these are not things that I'm making up. This is what is really happening out there. You've got a couple of other things that are coming about with this whole process. Increasing cost, lower benefits. Mike will talk about that. I talked about the lost support. There is one thing, and I'm not being facetious about this. This is serious and this is very true. There is one aspect of this bill that has worked flawlessly. There's one aspect about this bill that has not missed a beat. And that's every single one of the taxes that this bill calls for have been implemented, and they've been implemented on time to their fullest effect. So the one thing that you can count on is that bill going in place, and there's some very tough issues because of that, some perils I would call those. Very quickly, in wrapping up, perils of the existing law for employees. Coverage reduction, coverage dropped. Trader Joe's, I just saw this, came over the wire actually this morning. Trader Joe's has recently dropped healthcare benefits for all of its part-time workers. They just, we're not going to do it. And so what those people are going to do for their health care is they're going to be, if their state is expanding Medicaid or welfare, those people's option is going to be to go on to the Medicaid or the welfare program. So when you have government officials saying that this bill will not cause you to change your health care plan, try telling the people at Trader Joe's or Walgreens or any other place, UPS, that it isn't going to change your plan. It is. So there's definitely, and the sad part about it is we're becoming a nation of part-time employees even faster directly because of this bill. Physicians, subject to more useless regulations. There's more that are coming. Lower reimbursement, delayed payments with going into Medicaid. Tim can speak to that. When you take care of a Medicaid person, it's not that physicians don't want to take care of a Medicaid patient, but when you're getting paid 30 cents on the dollar and you have to wait 3 times as long to get paid, tends to make you not really excited. It's going to cause a huge shortage in physicians. 79% of the physicians surveyed this summer by the American Medical Association, who by the way supported this bill, 79% have a negative view of medicine, and it will lead to early retirement and fewer people going into medicine. Now, I know this would never happen with Tim, but how many of you would like to go under the care for a serious procedure with a physician who has a 79% negative view of what he's doing and wants to get out of it? I mean, there's some real serious things that are going on that people don't look about. Seniors, the tax, most of you know what the donut hole is with your medicine, right? Well, that tax is going up to the insurance, or to the pharmaceutical companies, up about 50%. So what you pay out of pocket for those drugs that fall into there, somebody's going to pick up that tax on that. Freezing the payments to providers in Medicare. Medicare providers facing a 21 to 22% cut. That's going to further restrict the supply of physicians taking care of Medicare. Employers who cover drugs for their retirees can no longer deduct the cost of their drugs and this is just a little carve out. And this is what's in this bill. So employers who have retirees on their health care plan can no longer deduct the cost of the drug benefit for retirees on that plan. So what do you think those employers are going to do for their retirees? I mean, it's pretty straightforward what's going to be coming down the road. There's predicting a shortage of physicians, about 125,000 by year 2025. Independent Payment Advisory Board is going to be recommending, when the government recommends, you know what that means, what will be paid for and what won't be paid for in the future. Medicare cuts, higher taxes on seniors, medical devices, drugs, and deductibility, that all hits everybody. The big one is the unearned, or the income, investment income, 3.8% tax that was added on. That was going specifically to fund this plan. Future generations speaks for itself. Future costs, people feel in the next 10 years have been underestimated by $1.5 trillion. So that brings the cost of this bill, which we were told was $900 billion, brings the cost over the 10 years to about $2.4 trillion. And that's low, I think, for some. This is not good news for the state of Minnesota if you want to try to change, but the real true power in affecting this healthcare plan falls with the state. Now, Minnesota happens to be a leader, but a leader going into the exchanges and going into full speed, so the chances of reform really lies with some of those states where they haven't quite gone into that whole process yet. There are aspects, again, of the healthcare system that have to be reformed. They need to be reformed. They will be reformed. Where we go from here, I wish I could tell you. A lot's going to happen in the next 6, 7, 8 days. You're going to hear more spin than you've ever heard in your life, trust me, in the next six days. And I say this last part to wrap up, not to be facetious, not to be funny, not to be a jokester or anything, But this is really true, and there were a lot of things said about this before, but it's more true today, and I said it to kind of wrap up 3 years ago, and I'll say it today because unfortunately it's more true today. But what we're going to have if that whole bill is put into place the way that it is, we're going to have a government-designed, run, and taxed product that combines the best government has to offer. And that is Pentagon price tag, post office efficiency, and the compassion of the IRS. And that's literally what's coming down the road. And it used to be kind of funny, but it's a little bit on the scary side now because that is truly what's facing us. I'm going to turn it over to Tim to let him comment from a physician standpoint, and then Mike will dive into a few more of the finer points from employers and employees, what they can expect, and then we'll open it up for questions and go from there. So.
Tim Gibbons from Mason City, Iowa. I'm an orthopedic surgeon in Mason City. I really don't have anything prepared to say, and I don't want to put myself out as I'm an expert of what's in this bill. I got to admit I didn't read any of the 2,900 pages, but I am somebody who is putting up with the regulations. And you know, physicians, you know, we're scapegoated sometimes, and sometimes deservingly so, about the cost of health care. But one of the things we truly do want is the best outcome for our patients. And when we look at outcomes, and I'm going to say that nearly a quarter century that I've been involved with medicine, after a while you learn how to read people. And the senior people here can say, you know, through life experiences you can see a train wreck coming. When you watch younger people live their lives, you know there's going to be a heartache, you know there's going to be a problem if you sit back and watch. It's a matter of time. And in healthcare, you learn how to read people that way. And what I look at this bill, and what it puts itself out is the Affordable Care Act. There's nothing that they did to incentivize people properly from a healthcare practitioner's perspective to assist people in making the healthcare costs go down. One of the interesting things this year, this is data from this year, the Academy of Orthopedic Surgeons republished, about you could predict outcomes by a generic orthopedic procedure just based on the insurance company. So if you're a Medicare insurance person, or if you're a private industry insurance person, that would be the gold standard of outcomes. If you're a Medicaid person, your probability of having a negative outcome is 1.8 times greater for your surgery versus the private pay and Medicare. If you are a workman's comp insurance person, your probability of having a negative outcome is 7 times greater than those people who are Medicare or private insurance. And why is that? Well, because there's incentives in healthcare that people, for people to get better or not get better. And the government in this bill has done the exact opposite what they should have done. They took the most inefficient ways of incentivizing people to do well and be responsible for their healthcare expenditures, and they made those programs bigger. A lot bigger. At the expense of the people that are paying their bills. You know, being a scientist of sort in medicine, I believe that there's certain laws of physics that apply, and when you tax something, i.e. people who have insurance policies and they're paying for them, and you tax the people that are paying their fair share, you're going to get less of them. And when you subsidize people to do poorly, i.e. workman's comp or Medicaid, you get more of that. And that's what they did in this bill. I can tell you, because you know, I'm practicing blue-collar medicine on call every 6th night, taking all the trauma people in North Iowa. You know, I get up in the middle of the night for the poor people, I get in the middle of the night for the rich people. Been doing that for 17, 18 years in Mason City. Yeah, I've never asked anybody if they can pay. Mercy Hospital takes care of everybody that we can. And so when people are saying they're denied health care, I want to know who they are. You know, the children in particular. We have a program in Iowa called Hawkeye, or it used to be called Hawkeye, now it's changed. And 97% of the kids in the state of Iowa are covered by it, that are covered by some health care. And the 3% that aren't, either they're Amish people and they don't want anything to do with the government, or their parents are so incompetent they don't sign up for the free insurance. And so when they put these statistics out there, there's 15,000 kids that aren't covered, well, that's a bunch of crap, because when you show up at the ER, we take care of you, we get you signed up for insurance, and everything's retro-dated. So there aren't, in my life experience, at the University of Texas, at the state hospital there, the University of Iowa State Hospital there, the fixed military facilities I worked in, there aren't people not being cared for. I don't know where they are. They're not in Iowa. They weren't in Texas. So I have my doubts about this bill. The regulations in the medical community is stifling. It's stifling. They're dramatically jacking the overhead costs for practices in hospitals, and some of the stuff appears to be like it makes sense, but in total it is stifling. And what happens when you regulate something? Another law of physics. You make it less efficient. You know, another comment when we talked about the President Obama said that he wanted everybody to pay. I didn't see the trial lawyers paying anything in this bill. And when you look at defensive medicine, you just look at my habits of how I decide when I order an MRI. I tend to do a lot of shoulder surgery in Mason City. So when do I order an MRI? When I don't know what's going on, I'm confused about what this person's diagnosis is. If they're workman's comp, because I know somebody's lying to me, it's either the company or the patient, it's one or the other. They're Medicaid, because you can never trust those people either, because they're 50% of the people are surveyed admitted that they lied to their physician on intake. And a personal injury lawyer. Or, like car accident, something's going on there. Only one of them had to do with what I was thinking. Everything else has to do with their thinking. And that defensive medicine, it really tacks on the bills. And it's so insidious. I mean, you just say the word attorney to a physician, they shudder a little bit, because there are a lot of good attorneys out there. My father has a law degree, believe it or not. And I mean, there are a lot of good attorneys out there, but there are a lot of people that parasitize the system, that enable people to fail. One of the great ways to determine what your outcome is if you have a lawsuit pending. If you have a lawsuit pending, the probability of getting over your orthopedic problem is essentially zero. And I'm not making these statistics up. They can be seen easily cross-checked with any data coming out of any of the national centers on orthopedic research. So I worry about this. I worry about it for my kids. I worry about it in my own personal practice. I think that the bill unfairly picks on the younger people, and the amount of expenses that they're going to have to carry in this bill is just, it will affect their ability to live the life that we've lived. So I guess I'll defer to any other comments as they come up. That's my opening remarks.
What I'm going to try and do tonight is tell you two different tales. One from the employer point of view, or how the law is affecting employers, and then from the individual point of view, how it's going to affect individuals in America. I'm going to start with the employers, and there's really two different types of employers when you look at how this law was designed. It's employers with 50 or more employees, or employers with 50 or less than 50 employees. So let's start with the one that is the employer that's less than 50 employees. They really do not have a requirement under the law
to provide health care coverage to their employees today. And that's going to be true when we get to 2014 as well. What you're going to see, I think you've heard the word regulation a number of times here tonight. You're going to see it's not going to be a really fast process, but it'll be slow and steady. You're going to see the smaller employers start to drop coverage because they don't want to deal with the regulations that come along with the law, and they really don't have any penalty for doing so. They're actually sometimes incentivized to do so because many of their employees may qualify for what's termed a subsidy under the new law. Many of these employees may actually get what I would call better and more affordable coverage if they have a low enough income to receive a subsidy. So let's talk more about the employers that are over 50 employees. These are the employers that are going to be affected the most. These are the employers that, while they're not required to provide insurance to their employees, if they decide not to cover their employees, they'll incur a penalty. Now that penalty is actually one penalty that was pushed back this year. Why? They said that the systems weren't in place to monitor it. But that penalty is going to be a non-deductible tax expense of $2,000 per employee, except you get the first 30 employees free. So if you're a 130 life employer, you don't offer health insurance coverage to your employees, you take 130 minus 30, gives you 100 times $2,000 a year. It's a $200,000 non-deductible business expense. So it's a pretty large increase over the cost that an employer is incurring today. So what can you expect prices to do from the employers that are falling into that category? Prices of their products are going to go up. Now, I work with a number of different retirement community homes. They are feeling pressures from every level. They're being directed, actually reimbursed. It's not them that get to set the costs or their revenues. They're reimbursed at the level that the government says. They are one of the employers that, while they offer coverage today, not a lot of their employees are accepting the coverage. So they're going to be impacted pretty immensely by this new law. I can just tell you across the board, most of them are scrambling to figure out what to do, how to implement it, whether they offer coverage or not. They're going to be implemented pretty largely. Other employers are service industry. A lot of the employers that don't offer coverage today, maybe a Subway franchise or some hotel franchises. Now, don't take it like I'm saying that none of them offer coverage, but these are the industries that are likely not to offer coverage today, that are either going to have to or incur a penalty. And is it a bad thing? I don't know. All I know is it's going to increase costs. So when you think about it from an individual point of view, pretty much every American is going to be required to have some sort of coverage once we get to 2014 and going forward. Whether that be Medicare, private insurance, group health insurance through their employer, the bill actually requires you to have insurance, or you pay a penalty to the government as well if you do not purchase insurance. You pay that penalty through your taxes at the end of the year. The penalty starts out pretty darn small. It starts out at $95 per individual. This is an annual number. It's the greater of $95 or 1% of your income. So if you make $30,000 a year, your penalty, if you did not buy insurance, would be $300 a year. Not a large number when you look at the scope of what insurance actually costs. I don't think it's going to drive many individuals right at the beginning to actually go out and buy insurance. It may drive a few. Like I said, there is subsidies potentially available for some of those people. how do you actually get a subsidy? There's really two basic requirements to how you achieve a subsidy. The number one thing is it's income-based. And the law, the way it was written, is it's 100% of the federal poverty level up to 400% of the federal poverty level. Some states increased their Medicaid expansion. In Minnesota, it increased it to 133% of the federal poverty level. So if you fall under that 133% of the federal poverty level, you're actually going to get Medicaid insurance. If you're over 133%, you've checked off that first box on being eligible for a subsidy. What most people don't get is the second part of the equation is being offered what's deemed affordable coverage through an employer-sponsored plan through you or your spouse. So if you can't check off that second box, you're not eligible for a subsidy at the exchanges. And what is affordable written in the bill isn't really what I would deem affordable. The way it's written is affordability is only written as it cannot cost you as an employee more than 9.5% of your income per month for employee-only coverage. It doesn't take into account your spouse or your dependents at all. As long as your employer offers you coverage and it doesn't cost you more than 9.5% of your income, they may charge your employee and spouse or your dependent children $1,000 for family coverage. It doesn't matter. You can't check off that second box no matter how unaffordable family coverage is to you, as long as they offer you employee-only coverage that's affordable. Most people that are actually offered employer-sponsored group coverage today aren't going to be able to check off that box. I think this is something that's going to come later, and they're going to realize the mistake they made. They're not going to get the people that actually need the help into these exchanges. So what happens if you already have group coverage or even individual coverage today? You're going to see, in many cases, some increases in your premiums. And this is, again, not across the board. Every employer is going to be different. And that's the hard part when you sit and talk to your neighbors. You may have gotten a 30-40% increase, and they got a 10% decrease in their premiums. And it's not going to seem real fair, but again, that's the way the law is written. It affects large employers differently than small employers. There's taxes built into the premiums as well. You're paying somewhere around 5% additional costs just inside of the taxes. Depends on what type of group plan that you have. Again, they're all different. So there's not a lot of clarity across the board, what I would call fairness, but I know everybody has their own version of what fair would be. So that's if you have group coverage, and will your employer continue to offer you group coverage? That's a big unknown. I think at this point you can expect most large employers will continue to offer group coverage until you see more and more of these large group employers start to drop coverage and it becomes more commonplace. When you look at the penalties a group employer would incur, they're a heck of a lot less than what an employer actually pays in health insurance premiums for their employees. It is definitely, if an employer looks at it only from a financial aspect, almost across the board it's going to make financial sense for that employer to drop coverage. But there's another part of that equation is most employers truly care about their employees. They want to offer them good coverage. They want to take care of their employees, and they want them to be happy. They want them to be taken care of. They want to attract and retain good quality employees. So I think you'll see most of them keep it for a while. Like I said, though, the small employers, it may actually be in the employees and the employer's best interest that they drop coverage. So you may really, really, really like your coverage, but you might have to go to the exchange anyway. Now that's not to scare you, it's just the truth is, every employer is going to look at it from those 2 points of view and try to make a determination of what's best for me and my employees as a whole. If you receive individual coverage, I'm not sure how many in this group would, or even if you do, if your employer today allows you to pre-tax that coverage, but that ability to pre-tax individual coverage is also going away. That's something we just learned last week. The Department of Labor just released that, and I can tell you it's sending hundreds of employers just across Minnesota scrambling, trying to figure out what they're going to do for January 1st. Because basically that deduction, which is for most people 20 to 35%, is going away. So their health insurance is not only increasing in costs, they're losing that 30% deduction. That lowered their costs as well. My last comment is going to be, the state of Minnesota has always been a progressive state with health insurance. I know the comment coming out of MNsure when they released the rates was that the rates on average in the state of Minnesota were the lowest rates that have been released across the country today. And looking at the actual rates that they've released, some of them do look very, very appealing. What you learn though as you dig a little deeper into the rates is that there's nine zones of rates in the state of Minnesota. And each zone is able to be rated differently. And I can tell you Southeast Minnesota is taking it on the chin when it comes to small group employer coverage and individual coverage. Our rates are higher than anybody else in the state, and it's not just by a little bit, it's by a pretty wide margin. Now this isn't large group, this is small employers under 50 and individual coverage for the under 65 market. So if you have that, wait for your renewal this year. With that, I'll turn it back over.
Okay, what about the average for retired persons? How is this bill going to affect retired persons?
I think there's two different types of retired persons that you can talk about, how the bill's going to affect them. The one I'll speak to, probably not the one you actually want to know about, is the retired person that's under age 65. This type of person, it really depends on, how big a pension you're drawing, how big of assets you have that you're taking out of some sort of taxable retirement plan, so say a 401k retirement plan. Because remember, the subsidies that are built into the law are based upon your income and access to group health coverage. If you're retired, you don't have access to group health coverage. This means you check off that box. If you have a low enough income, you're going to receive a pretty sizable subsidy in the form of a premium tax credit, as well as potentially part of your out-of-pocket costs for claims picked up by these subsidies. So, in actuality, it changes the game for how a younger person may plan for retirement, assuming this law would still be there when you actually retire, is that you could retire before age 65 and receive some pretty cheap healthcare costs.
I think just to add on to that, a couple of other things that are not advertised that are going to affect the whole situation is the fewer choices for seniors with the freezing of the Medicare Advantage payments in 2011. It's causing physicians to rethink the participation in that. I think that you're going to see fewer and fewer physicians participate in the Medicare Advantage. The other thing that you're going to see, and it's already happening across the country, and it's not by design, it's not because they want to, but it's the mere fact of trying to keep the clinic afloat, trying to keep the organization moving. Our clinic, for example, is that we are severely going to be increasing the cost of healthcare for our employees. because we have to with the number of the taxes that are coming out, a number of different things. The other issue is, I think, where the effect on seniors is going to be just the sheer number of physicians who are going to be taking early retirement, that are going to be exiting the system at a time when we have more and more people coming into their years when they need health care, is where the shortage of physicians is going to really start to kick in. You're also seeing some medical groups across the country, they participate in Medicare, but they severely restrict the number of Medicare patients that they're able to treat just because of the payments and trying to keep the doors open and trying to keep the organization moving forward. And if Medicare does what they're talking about this year, and they put that 22% cut through for physician reimbursement, when Medicare right now, and I don't know what it is with the Mason City Clinic, but I know in Waterloo with our clinic, is Medicare reimburses about 32, 33 cents on the dollar, and you put a 22% cut on top of that, it really becomes a direct tax on the healthcare system for senior citizens. And those are some of the hidden things that are going to affect seniors.
Maybe we could take that just a step further. The question here is, what will happen to healthcare for seniors when $750 billion is taken out of the Medicare Trust Fund to help fund Obamacare? And I'm not sure, is that the correct number? What's coming out of there? And you've elaborated a little bit here, but it goes on, will doctors have to ration care?
Well, that's exactly what they want us to do. I mean, they want us to ration care, but they don't have the courage to do it themselves. I mean, my brother ran for Congress in South Central Iowa a couple years ago against Leonard Boswell. He didn't win the primary, but I just watched him go through that process. And my brother was a wrestling coach at Iowa State University, and he's a go-hard guy. And his comment after all that it left a little bit of a bad taste in his mouth involved in politics. He says, "I've never seen anybody work so hard, or this group of people work so hard to try to do a job, or try to get a job that they don't want to do." And that's what I see in this Obamacare, is that they're trying to figure out, they promised it to everybody, and they know they can't deliver. And then they want to put the moral dilemma on us to ration the care. And so they keep on creating these systems that allow people and the systems to fail. You know, one of the examples I like to give, my two busiest months of the year are November and December. Partly it's because I live in North Iowa and I deal with a lot of farmers, and when they get out of the field, they want the surgery done. Everybody's deductible is met for the year. They want to get it done before the first of the year. These are real practical reasons. Football, basketball started up, got a lot of kids hurting their knees or whatever, and you put two major holidays in there, and from November to December, if you want an elective surgery in Mason City, you better have scheduled it a long time in advance, because you may not get it. And that reflects, human nature. It's like being in the smorgasbord. When you don't have to pay for it, you're going to leave a lot of food on the table when you walk out of there. And that's what I see in healthcare. When people deductible met, hell yeah, give me an MRI. I'm not paying for it. I got my deductible met. With no sense of what it's costing somebody. I had a good friend of mine, retired oncologist in Mason City, just retired this last month for his own health reasons. And I asked him this question once. I says, when you have a patient that you have a 5% probability of living through this cancer treatment that you're going to initiate, and they have to pay for it themselves, what decision do they make? They said they never go for it. They want to start talking about the funeral arrangements. And he says when the government pays for it, they take it 100% of the time. And that's human nature. That's what I would do. When my deductible is met, I'm more inclined to have the elective things. I'm trying to push it because that's what makes sense to me as an individual. And then said, that's what I have a problem with this healthcare bill, is it sets the incentives for failure, not for success. It sets the incentives for spending more money, not less. It puts the pressure on the people to bring healthcare costs under control that really shouldn't, that didn't promise. You know, I promised to help people. I didn't promise to ration their care. And the government made a promise that I can't keep.
I think just to take off, there's a couple of other things I think that people need to, take a real serious look at this, is when you look at that bill that was put in place and the price tag that we're going to be paying in excess of $2.4 trillion, really it's the opposite effect, and there's a document here that states it very, very well, is it said that the leaders of the country, and that goes for all of them, have argued that a primary benefit from the health care law will be reduced long-term budget pressure and thus a brighter future for coming generations of taxpayers. But when the cost estimate is adjusted for the omissions, the gimmicks, the double counting, the unrealistic assumptions, it is clear that the new health care law will increase the burden, not lessen it. And there's a couple of key statistics that you really need to think about as you talk to your legislators and as you go to the voting booth when you do, because this, like I've said numerous times, this is serious stuff. If the government accountants would have done their homework, they would have been far better off to go and buy an off-the-shelf insurance product from Mike to insure the uninsured, rather than spending all the time and money and energy to put this system in place. And that's a mathematical fact. When you crunch the numbers on it, you would have been better. But this plan is complex by design, and I think that it is pretty relevant that the people that have really been pushing this really wanted a single-payer, British Canadian style single-payer system is what they wanted. They knew that they could not get that. So what you have in front of you, and it's the only thing that makes sense to me, to have a 2,900-page bill with 15,000 pages of companion bills, the only reason that they wanted to push that through was to create something so complex, so unwieldy, so doomed for failure, that people would throw up their hands and say, go all the way and take care of us with the Canadian-style system. And that used to be a conspiracy theory, but anymore, if you truly look at what's in the bill, that is reality. Maybe we can come back in another 2 years and see how right we were on it.
Yeah, the exchange, it was definitely a foreign term to me as well when it came about. But basically, an exchange is, to put it simply, it's a place to go shop at. I mean, you can think of like the Mall of America. If you went to the Mall of America and that was the Minsure Exchange, there'd still be all these different stores in there that sell all these different types of things, but it'd be the most boring place you've ever went. They'd all be carrying health insurance plans. That's what an exchange is. Think of it like an Amazon or an eBay. It's a place to go shop, and it's a place for you to compare these things that are foreign and confusing to you, healthcare plans, and a way to purchase them, and a way to deliver subsidies as well.
If the Affordable Care Act is not delayed, defunded, or dropped, will we still have Medicare?
That's up to the legislators. I mean, I would assume so. Medicare is a popular program. It's really done a lot of good for a lot of people. I don't think anybody has the nerve to eliminate it.
We're going to ask for a little clarification here regarding Senator Vitter is trying to pass an amendment, and I think is he trying to bring back what Grassley had tried to do originally? And the actual agreement that exempted Congress and their staff was kind of an agreement between the president, and I'm not even sure there was a bill passed, was there?
That is correct. What Grassley had done is he had sought to provide the legislation that would eliminate that subsidy that was in place. And you're exactly, so what Vitter did is he put a bill on the floor, and then I don't know exactly how it all works, but it didn't get to the floor. It didn't get discussed and open, but then through some executive fiat or whatever, they were able to reverse what Grassley had put in his to allow that subsidy to go back in place for the Senate and the Congress as it stands now. That was my understanding.
An agreement was made between the president and leaders of Congress to exempt them from Obamacare and give them back their subsidies. There is trying to attach an amendment to restore the Grassley provision that they have to live like the rest of us.
Okay, all right.
Did everybody hear that? So Vitter is trying to do the same thing that Grassley had tried to do from the start. He wants to make Congress and their staffs part of the Affordable Care Act. They have to take part in it too. It's good enough for us, it should be good enough for them, right?
Does that include the Senate as well?
Should be Senate and House. Should be all Senate, House, and their staff. A question on navigators. These are people that are coming in off the street, and they'll be taking some personal information, financial, medical information. Is that information going to be safe? How are they being trained?
You know, I don't know one single navigator, so I don't know exactly how they're being trained. I don't know if the information is going to be safe. I know there was a data breach just a short time ago by an employee that I read a story that is no longer with MNsure now. You know, I think the important thing to know about a navigator is they're there to help you if you make a call, but by no means do you have to utilize a navigator. I mean, you can go see almost any benefit professional, insurance agent that deals with this healthcare industry and look at buying a plan that's available through the MNsure exchange through most of those people. You don't have to use a navigator.
Rich, can I make a comment?
Yes.
Because that's my question. And from what I understand, the navigator is in that section that's in that pile of stuff over there. There's no background checks for them or anything. And that they will have access to our information. That's what concerns me, is just data privacy and, you know, you give people that no background checks, our social security numbers, our medical information, and that's just a big concern to me for the general public. You know.
I think it's a valid concern. I really don't know that much about how MNsure's run. I know I sat through a presentation by MNsure, but really am given no information on how they run their organization or, you know, how they do background checks. I know there was an issue with one of the organizations that received a grant as well. I can't comment in depth on what that issue was. I know it was there.
Is it required for seniors to have life-ending consultations every 5 years? And who is going to do that?
I don't know exactly what the rules are, but that is true that there are measures in there that, I just heard about this last weekend actually, about life-ending directives that you have to have in your electronic medical record someplace. Now, the cadence that they have to be updated on, I can't tell you. And if physicians don't have it in the chart when audited, then we're fine.
It is true, and it is buried in the bill, and there was a big debate about that, whether that was in there or not, but that's that advisory committee, which is kind of a nice word for an organization that, there's a Medicare Payment Advisory Committee, and Dr. Gibbons knows as well as I do. Once that advisory board speaks for Medicare reimbursement issues, about 99% of the time it becomes law. And so this advisory committee, if it falls under that same process, it is in the bill. It does talk about this committee requiring that type of activity to take place between, especially a primary care physician and their patients, to have that plan.
That was a lie. I can tell you that one of the things that I didn't say in my resume is that I actually purchase healthcare insurance for a lot of people. I'm on a board of a company called S&P. We manage ambulatory surgery centers. We got a half dozen or so that we're part owners in, and and a dozen or so that we, our managers are, and we actually manage a couple physician-owned hospitals. And so as a member of these boards, I help purchase people's health care insurance as well. And one of the things that we talked about this last weekend was, oh, well, how are we going to handle this as an employer? We got literally hundreds of people and thousands of lives, and we have this insurance, our advisor from Silverstone is a company out of Omaha, give us a talk and a presentation on this. And one of the options for us that's on the table yet is that we do a defined benefits program. We're going to avoid all the taxes and regulations that Obamacare is putting on individual employers. And basically, I say, here's $5,000, do what you want with it. But you got to go buy health care as part of the deal if you've taken the $5,000. Now, I'm explaining this from a physician's perspective. I don't have an MBA. I'm just telling you, I'm just kind of regurgitating when I heard this on Saturday. And so it occurred to me, what a clever plan. They make it so onerous. They tax me if I buy health care insurance that I'm giving to, or that we're providing for the employees. But they give me an out. They can take some of the pressure off of me if I just give you the money and you go find it. Well, where do you go? You got to go to the exchange. And who's running the exchange? The government's running the exchange. And hence, it was a lie. You can't keep your health care insurance. They are going to change it.
The person that's on Medicare and Champa, I believe that's for military, correct? What effect will this have on them?
I would be speculating a little bit on that, but the one thing that probably is going to remain intact more than any would be the veterans benefits, if it's VA, if it's under that whole process. I know that they're kind of staying hands away from that. Now, whether Champus is going to fall into that, I'm not sure, but I think going back to what Tim said, is they're going to tinker with the Medicare stuff to a point, but I don't think they're going to risk an all-out political war by doing away with it or removing that. But I would talk to, you probably have somebody at your local hospital here or somebody who's an expert in that area that could tell you exactly what's coming down the road on that, but I don't know specifically.
I'm a veteran. I was in 2003. I spent that year in Iraq, and so I have veterans benefits. I don't use them, of course. I work at VA hospital. My wife actually manages the facilities of the VA clinic in Mason City, and I don't think they're going to mess with the veterans. But it does. There's a curious thought: is why do we have a veterans program, an American Indians program, a Champus program to dependents? You name it. There's so many programs. Why don't they just give everybody a Medicare number and give them the benefits there? Why do they have that? You drive X number of 100 miles to go to a VA hospital. Why don't you see your local doctor if you like it? And do it and give you a Medicare card. That never made any sense to me at all. But I don't think this was too much sense.
I was just going to have you clarify something. When you talk about these navigators and this exchange, why didn't they just use the private insurance agents to do that?
Well, maybe Mike can help us with that.
Yeah, I'm not sure why they didn't do that. I know they certainly didn't invite a lot of input to the table from the broker community. I know we're a pretty vilified crew that are looked negatively on many times, and I think they thought when they were originally putting this together that we were probably part of the problem, and we're really not. We're there to help people, and sure, we're paid to do so by compensation built into many of the products. What they did was they put some limits in place for what the compensation could be. Minnesota, Iowa, these aren't states that had serious issues with that, but there are places across the country that had probably some pretty serious broker issues. I can't answer why they did not provide a different avenue. I think they were looking for somebody to provide an impartial point of view, but in actuality, if you go to a navigator versus somebody that can actually provide you advice, tell you what is the best plan for you to choose, they can only provide you information on what the plan is. They can't actually make a recommendation to you on what would be the best plans for you and your family. Well, I'd like to just thank everybody for coming and thank everybody for inviting me to be on the panel. I think when you look at healthcare today, it is a very dynamic thing. I think it's going to be ever-changing over the next 5-10 years. I think it's going to look completely different in 10 years than it looks today when you're looking at healthcare and how you purchase it from an individual point of view. I think defined contribution plans are going to become a big hit. And to explain to you what that is like was mentioned, that they give you a bucket of money to go spend and access to this plethora of health plans, and you get to go shop on your own. You know, this is what's coming. It's very, very similar to the retirement plan industry. If you think back to the early 90s retirement plan, defined contribution, this is what's coming in your healthcare in the future.
Thank you, Mike.
Yeah, I guess I would just say is stay educated, stay involved. Be careful what you hear on TV. Do your own research. There is so much information out there, so many good summaries of what is going on. I would talk with your legislators. I still believe in the legislative process. I think that what you're doing here tonight, you should all be applauded for. It is one of the things that is a byproduct. What has come out of this is that people are starting to talk. I think people are coming together. The one thing that I always say about the political process, which is really almost sad, is that you could take this group of people right here, and we come from different walks of life, we come from different religious beliefs, we come from different economic levels, we come from different backgrounds, but the one thing that we can do is what they cannot and what they will not do in the legislative halls, especially in Washington, is they will not sit down and talk and have meaningful discourse and dialogue with people. And I think it's an absolute shame that they won't do that. And when they will come, when someone comes on, I've been negotiating for all of my life what I do in healthcare. And when you have somebody comes out and says, I will not negotiate at all, period. Now let's talk and figure something out. It's the most asinine, stupid thing I've ever heard come out of anybody's mouth. And that's not a political statement. I'd say the same thing if the person saying that was of a different stripe politically. It makes absolutely no sense. I don't think it makes sense to any of us in here at all. That's not how you do it. You figure it out, you sort it out, and you come up with something better. And part of what we have had is, unfortunately in this country, is we've got a complete reversal that they feel in the state houses, and more so in Washington, that we all exist to support them and their re-election bids and their re-election campaigns, then they are there as our employees and our representatives. So I just say stay involved. This is just the tip of the iceberg of stuff that's coming down the road at us, and you got to stay involved. Don't give up. That's what I'd leave you with.
I agree with the other two gentlemen at the table here. It's a complex bill. Where we're going with this, who knows? As a Christian and a practicing Catholic, I think it's my obligation to take care of the poor. I think the motives behind a lot of this bill were good and sound to help cover more people. I think the incentives behind it are doomed for failure. What I've seen in my life as a practicing physician is how medicine can be politicized, whether it's HIV or dialysis or you name it, whatever disease that you get enough people behind, you can make special arrangements for it. And that's what happened in this bill, is that I think they made a colossal mistake. And I believe that the motivations is to have a failure, and so we go to a single payer system. And that's unfortunate, but that's kind of what I believe and what I believe I'm observing right now.
Thank you. Just a couple things before we wrap up here. We can go ahead and do a round of applause.